Hi guys, good evening. It's me, Dr. Jenny Yusuf, physical therapist and doctor of physical therapy, creator and founder of Balance and Fall Support Group in Aging Adults, and previous vice chair of Global Health in Aging Adults. I'm the current state advocate in Delaware for geriatrics. First of all, welcome, and it's another thanks God it's Thursday. For tonight, we're going to interview an amazing person. She is Dr. Jennifaye Brown. She is a stroke rehab sage. She has continuing educations for gait analysis and treatment, especially for AFO designs. And she has an amazing book like Brace Yourself about AFO and stroke. It's available in Amazon, and we will talk more about it and how she helped lots of different stroke patients, not even stroke, because she's a consultant for our aging and older adults in her place. Where is it? In South Carolina, Charleston, right? Yeah, so it's the same time, East Coast. So she's a fitness expert and a PhD for in exercise science, certified aging in place specialist, and she's the only one neurologic physical therapist in her place, which also doing caps more on certified aging and home modifications. And also, as I've said, she's a board certified in neurologic PT because she's more than almost like 35 years. She's a retired clinician. She has a master's in physical therapy, and she is a graduate fellowship in education leadership. So she's really more on clinical educator. She has even an advanced clinical and credentialed clinical specialist. So now she is retired, and but now she's doing more on consultation to continue helping our aging and older adults. She's doing aquatic therapy just before our interview. She just have finished her aquatic class. So let's learn more about Dr. Brown. And remember, you will not miss her. Her name is so unique. Jennifer. I'm Jennifer. You meet lots of Jennifer in the world. We are almost six Jennifer in my company. And now we have Dr. Jennifer. It's my first time to see Jennifer. I only met one Jennifer, which is a male, but this Jennifer is only Dr. Brown. Welcome, Dr. Brown.
Thank you for having me. It is a pleasure to be here, Dr. Jenny, as I see you call yourself.
Yes.
Um, yes, I have retired at the age of 57 in 2024, and I decided that at this time I needed to step back and really consider what is it that I do best and what is it that I want to do to have impact. And what I really do well is analyze gait. And I'm a stroke specialist, but it's any neurologic gait. I've done incomplete spinal cord, and then find the tools, including exercise and physical activity, to make walking not only just efficient, but more purposeful so that people can engage in life. And socialization is so important in movement. And I want people to be able to move efficiently, but move with purpose and be engaged. They don't have to be in their homes, they can be out and about. And so I really started looking at how could I best help people with their walking efficiency. They need a better brace. So I took all of my research that I did about asking individuals with stroke about their perceptions of their AFOs, and I did research on that. And I took all of that information plus my clinical experience and wrote a book. It's really patient centered, it's person centered, but there's a chapter in there that has the full examination what a physical therapist should do. It has a full chapter in there on what the orthotist should do. And there are quite a few chapters that empowers the individual with stroke of what questions to ask and what to expect from the physical therapist and the orthotist. I'm most happy when I can go into people's homes and say, if you want to walk safely in your home, let's get rid of the high pile carpet and the linoleum here and the wooden floor here. And let's just get one surface. Let's make sure your brace is appropriate for you. And let's get you walking efficiently in the home. and then let's go to outside, and then let's go to the community. So I want to really keep people in their homes.
That's really good, Dr. Brown, because I am in an acute inpatient rehab, and
Mhm.
I met lots of stroke patients, and I was surprised. We have an old stroke, and
Yes.
surprising that they don't even have a brace. So
Yeah.
when is the right time for them to have a referral for a brace?
Okay, so in inpatient rehab with the changes in Medicare that occurred in the late 1990s, 2000s, I do believe that's when they stopped giving the final permanent brace in inpatient rehab, and you had to be discharged to outpatient or home health in order to get your final AFO. You should mention that, and I'm bringing up insurance. In April, I had a paper published why it's so difficult to get braces reimbursed and paid for by the insurance company. And I did the research and I asked therapists, what do you know about outcome measures related to AFOs for their fit and function? There isn't one that's all encompassing. If you have an amputation, there is one all encompassing outcome measure called the AMP Pro or the AMP No Pro. And the insurance companies respect that data and they will reimburse for AFOs. So, when is the right time? It depends on the lesion location, size, and severity. Severity meaning time without oxygen. If you don't need an AFO, don't wear one. If you have that slight foot drop and it's a sensory problem, I put them in a elastic band, a TheraBand.
Mm,
And what I want them to really do is push off and then use the tension of the TheraBand to bring their foot back up. I've written a couple CEU courses where I have showed different pictures of using the TheraBand to pull the foot up to control knee hyperextension, to get the forward movement of the pelvis
mhm,
and activate that gluteal muscle to help maintain proper stance. So there isn't a right time. If they're in acute, I try not to restrict the tibia movement forward. I give them an off the shelf AFO if the facility has one, and I use tension bands, um like the what you put in your waistband of your pants, and the thicker the tension, the more the tension, the weaker the muscle is. The stronger the muscle, the least amount of tension. So I allow the tibia to move. I don't restrict the tibia. The AFO will hold the foot up. That's all it's supposed to do. It's not supposed to restrict the tibia. So in acute care, I use an ACE bandage,
yes.
TheraBand, off the shelf AFO. When people go home, then it's time to get the final AFO. You know, rehab time has shortened.
Mhm,
The sequelae of stroke and the negative effects of strokes continue to play out in the brain for 4 to 6 weeks. So you really don't know what's left viable in the cortical spinal tract, anterior and lateral, if it is damaged,
mhm,
until about 3 months afterwards. So sometimes we're putting people in AFOs and restricting them, and we're inhibiting movement. So a long time ago, I stopped giving out hinged AFOs and I give solid ankles, and their thickness is different on the walls, the shafts, the side, the floor, depending on the compartment weakness of the muscles. And everyone gets a tension strap. I also measure the ankle in supine, laying down, sit, or stand, and I assess for contracture because we know that the vestibular system will change the output of the lateral vestibulospinal tract. That's in charge of keeping your body straight,
yeah,
and that often impacts the lower extremities. So I measure the ankle in different positions, and I have found that I've been able to get my heels of these AFOs to really be encapsulated by the AFO without all the rubbing at the malleoli. I really do a thorough examination. So again, the perfect time depends on lesion severity, location, and how large it was. And then it depends on the time placement of the person. But more than likely, they're not going to get their final AFO in inpatient rehab. You have to makeshift what you can use.
Yeah, okay. Because not, I was just surprised. We have an old CVA that has multiple falls coming back, almost like 6 years, but I was surprised not having even a brace. But it's been a while, you know. So maybe that's why I want to know, is it us as a therapist with all those home health, with all those different therapists he met from outpatient? Is there a miss that nobody even assessed that this patient needs to have a brace at one point to help him with his skate training, or something that the patient may be not compliant enough that he just maybe don't wear it, I just don't want it, because I'm sure we're very good in promoting AFO if we find the foot drop or whatever.
Right. So I wouldn't wear my AFO if I had to wear a shoe size larger and wider, because now I'm gonna have to buy two pairs of shoes
Yes.
to fit the other foot. So we want them to wear the brace, but we didn't get a brace that was person centered for the function that it needs.
Mm-hmm.
All right. So that's another issue. And people can't afford to buy two pairs of shoes, two different sizes. And so we need to really think about how we're making the brace and why we're making it for what impairment. So you have to make a triage of the impairments and what you're trying to impact the most. I bet you that person probably did have a brace and didn't like it and does not wear it. And we need to look at that brace and see this is the foot, this is what the foot and leg looks like. But you look at the brace, it has no shape of the foot and leg. And
Mm.
so when I was doing my last set of research, we started trying to do a scanning protocol. And I was writing the algorithm for the thickness and the flexibility of the AFO based on the muscle weakness, tone, and spasticity. How many therapists actually measure those three things? Isometrically, concentrically, and eccentrically. Because we know we weren't taught that traditionally
No, not.
in physical therapy school. And gait is highly eccentric. So how are we going to fix somebody's leg in an AFO or give them a hinge and they're not even strong enough for the hinge mechanism to bring the tibia forward? So I don't think it's probably always that the PT didn't think about it. They probably thought about it and they said, the orthotist is coming to cast you today for your AFO. I bet you that therapist didn't provide the orthotist with any data, examination data regarding all the impairments at the body structure function level as well as the activity level. I bet you that data didn't include anything what the patient wanted. I wear a skirt. I want the AFO to be flesh tone. I'm a secretary. I'm used to wearing a low heeled shoe to work. Can we make it thin enough and flexible enough that it will fit in my tan wedge shoe? So I think sometimes I often give the benefit of the doubt to the client. I had a consult maybe last fall. There were three AFOs in the closet not being worn.
Oh, so that's really a good point. We need to know what are their wants. That way
Yes,
they can use it, and what they
yes,
really do. Yes, and also like the functionality and also the financially. I like the you
right,
emphasize on that. I agree because every time we're practicing the AFO, we ask them to buy a shoes because you will be swollen. Now but you have another AFO that will be another bigger size for that. So that's
right.
really all good points for that. Do you partner with an orthotist, Dr. Brown? Because you're
Yes.
really very detailed in doing that. Mm-hmm.
I am. And so I've had the opportunity to work with quite a few orthotists in Charleston. And if you purchase my book, the person who wrote their comment on the back of the book mentioned someone. His name is Dave from Hanger here in North Charleston, South Carolina. And this is what it was like. And I mentioned this in the book, shared decision making. Me, the client, the caregivers of the client and Dave all sat down and we all talked. And it wasn't more than 30 minutes. Dave, this is the reason why I did this, this, and this for the prototype of the brace. These are her outcome measures. These are her measurements. What is it that you would like to add for the stability and the type of plastic that you're going to use so that she'll be comfortable in this brace? It was all shared talking. And then we asked her, well, was the previous brace rubbing in this shoe? Was it rubbing in that shoe? Which shoe do you think you're going to wear the most? And do you know that client, they went back at, I think, the beginning of the academic school year last year and got a second AFO just to have as a backup because she walked so much and they wanted another pair. They said it was the first comfortable one that they've ever had, and she's been wearing AFOs all of her life,
Wow.
and it fits in different shoes. And so that's why they wanted a second pair. So just that communication, shared decision making. In the moment, I was valuing what she, the client, was saying and what she wanted. So she felt heard, she felt respected. And that's why they went back and got a second pair. And guess what? Dave didn't have to call me about anything because he knew the nuances of my brace. He knows that I like them thinned on the edges and flared away from the skin. He knows I don't like a solid Velcro strap with the metal loop. He knows that I don't mind that it covers the malleoli, but the tibia must be able to come forward without rubbing with the, so how he contours the malleoli in the brace, it has to be able, and if she doesn't need the if she's not supinating, then we don't need that extra space. We need to allow pronation and tibial internal rotation for the midfoot as the tibia goes forward. So he really knows how I do things. He took the time to listen to me. And again, it's communication.
That's really good. I'm sure that the those function, I want to emphasize, why are we pinpointing here or highlighting the essence or the importance of AFO? So you're focusing, Dr. Brown, more on post-stroke, right? The bracing
Post stroke.
post-stroke. Yeah, can you just tell us the benefits of having an AFO for our listeners, especially May is Stroke Awareness Month. So why,
Yep,
and not all stroke has also having issues in
exactly.
their legs, right? But we
Right.
want to pinpoint that some stroke patients has those foot deformity. Go ahead, doctor.
So I would like to start off by saying everyone doesn't have a dysfunction in their leg because they got early stroke care. That original stroke lesion, the black infarct that they see, it didn't have a lot of water come in and compress other nerves. So getting early stroke care reduces the impairments that you will see. I've done lots of recent stroke talks to stroke support groups, and
Yeah.
people say, oh, none of us have an AFO. And I said, you know what? That's because you came in and got early stroke care,
Mm.
because they can give you medications to reduce the swelling and the
Mm.
cascading effects of stroke. So that's the first thing. The second thing is you need an AFO because when your foot is dropped, you will trip and you have to do extra work at the hip and the knee to clear your foot. That eats up your energy. So if we can just clear the foot and make it horizontal to the ground without blocking the tibia, it will help for good, efficient walking. Why does there need to be efficient walking? You need to be able to walk briskly and safely, little sweat on your head, a little huffing and puffing, because at that level of intensity to get your heart rate up, you're releasing good neurotransmitters, good hormones into your blood system, something called BDNF, and we'll just keep it at that, but we'll call it BDNF, is released into your blood system. And those things go to your brain and help repair the nerves that weren't damaged from the stroke. And those that are viable are called the penumbra. They're in the area of the penumbra. But how do you activate the healing of the penumbra? You have to do high intensity exercise. The easiest and freest type of exercise, walking.
Dance
And
walking, yeah.
so that's why I want to do it. The third thing is the importance of the AFO.
Mm-hmm.
People want to be able to socially engage and look appropriate when they go out and about. They want to be able to wear what they want to wear and choose what they want to wear. So I just started to making AFOs that fit in women's shoes. But then when the duck hunter came along and it was fall season, I had to make an AFO that fits in the boot, in the Cambo boot.
Yes, yes.
So I have to change my perspective of what we're traditionally taught to make an AFO to accommodate the person and the activity of the person. And those people who are going out and about and engage in society are happier. They are doing much better in terms of their health. Socializing with people is very intellectually stimulating. It drives cognition. It helps to age with clarity, and people respond faster. They're engaged in community. People with aphasia are, when they walk better, they talk better.
Yes, yes, of course. Yeah. Mm-hmm.
Yes.
And this
So
is
those,
really important. Now they make us, we made them more functional,
yes,
independent. And then the more social they are, of course, less depression it will be, right?
yes,
Yes, and that's what we
yes,
want, this community, happy community. But
right,
this- not even not only that what you're doing, Dr. Brown, you're doing more on continuing education as what you've said, but you're
yes,
also a consultant, especially you're doing certified aging in place, more on your
yes,
CAP specialist, but doing home modification. So
right,
it's really linked in as a master of physical therapist and also a fitness expert and PhD in exercise science. Why it's important? Because my what I educate always is decreasing falls, balance and
right,
falls, right? So for us, fall prevention and fall, of course, learning how to get up from a fall. But in home modification, definitely our goal is to be able to live safely in your home and stay in your home
exactly.
independently. Tell us more about your consulting, like how you help them.
Okay, so the first thing is I will hear either from the spouse, well, when he was here, he didn't have any falls. That's because we would raise the bed high enough or the mat high enough so they wouldn't have to sit on a low surface to generate the force to get up. When actuality, when we're an inpatient or outpatient, we should have been working on the height and the type of surfaces that they had in the home. So I go into the home and says, the reason why so and so is struggling from getting up from here is because of the cushiness of this cushion. Let's go find some scrap wood, count it in a square. Does he sit or she sit on the left side of the couch or the right side of the couch? Let's add some wood under here and then let's add some door stoppers or the shimmers that you put underneath the cabinet and raise the back. Now, for the exercise, instead of starting the one and two and rock, let's start them off high, standing up and squat and pretend you're wiping your behind. Let's work the eccentric component of sit to stand first and then lower them down to the surface and then quickly get back up. Quickly
Mm-hmm.
get back up. So
Yeah.
eccentric stretch, then shorten concentric. Instead of working on let's sit to stand and rocking. First of all, can we, if the couch is deep, it's hard to stand up with your buttock way to the back of the couch. Let's
Yes,
scoot up to the edge and
exactly.
let's work the horizontal component. Let's go from a posterior pelvic tilt, anterior pelvic tilt, lean forward against the resistance of my hand. Horizontal component. There's no nose over toes. Everybody should have their nose parallel to the floor and their chin parallel to the floor. Because if you're down like this and you're
They're,
trying to stand up, you're going to go down to the
they're
floor.
stuck.
We need to go. So why we keep telling people nose over toes? I want their nose horizontal or parallel to the floor with their chin and not like this.
We tell them
And
nose to your toes, but we ask them to look straight later. They're stuck the nose to.
exactly. It's nose over toes. And that's why people are rocking because they need momentum to stand up because of the curvature in the back because they're looking down at their toes. I
Mm-hmm.
need to be upright and lean forward. And so there's plenty of ways to strengthen that. I put TheraBand on the back of the chair and I loop it around their shoulders and they're doing this and they're doing this and they're doing this. So I go in and I look at the pieces of furniture. I look at the levels of the floor. If they have a visual field cut and they actually can't see and they're running into the walls, I say, turn your head so you see the red strip on the door. You'll go through the door because the red strip turns your head, turns your body into the middle. If you have a visual field cut and you can't see anything, you're going to run into the door. So sometimes I trim the edges of the door with red or green electrical tape.
Mm.
Or we have the flashing white or colorful lights at Christmas. I
Mm-hmm.
have
Yeah.
motion detector lights. So when the person is walking, it flashes and the person knows, oh, every time I see a flash, I need to shift 3 inches to the right so I don't run into the door. These simple things will help people stay in their homes. And guess what? It's cheaper to be in your home than to have to go to an institutionalized setting because when they go to an institutionalized setting, they're in the room with one person. You have to share a TV station. You don't get out and about unless there's help. And we know that there's one LPN. The RN is the charge nurse, one LPN per floor, and maybe one tech per floor. And there's 24 people on the floor. That's
Out.
not the kind of care you want. You
Yes.
want to remain in your home. So I've done things with kitchens, with bathrooms. I always tell them, well, where's your rec space? And I said, the rec space cannot be the chair that lifts you up or, I forget the lazy boy chair.
Mm-hmm.
I
Yeah.
need the rec space to be maybe a ladder back chair where you're sitting upright, you're playing cards. Where's your library station? You can't do everything from the lazy boy. And
Mhm.
if you're in the lazy boy, every time the commercial comes on, I need you to push down the lever, stand up, walk around to the right, and walk around to the left for every commercial that comes on with the TV.
And there's lots of commercial nowadays. That's why we keep
Yes,
saying that too, right?
yes.
The
Because
sad
of
thing and
sedentary behavior post stroke. And so you have a phone all the time in your pocket.
Mhm.
It can track how many steps you take. You can
Oh yeah.
have a wearable on your watch. You can
Your
get the
app.
old fashioned pedometer, but we really need to track not only the number of steps, but how fast we move safely. So I always do fall prevention and fall recovery. If the average physical therapist would just engage the person in the developmental sequence, and that means put them on their back, make them roll over, get them on their stomach. Oh, I can't get on my stomach. Let's try because you're going to have to get on your stomach if you're going to get from the floor or crawl to the phone. I can't get into kneeling because I have arthritic knees. Get a
Mhm.
chair with arms and put a pillow in the chair. And let's get up on the chair one knee at a time on a soft pillow and practice bringing your butt low and up high. The reason why your knees are arthritic and they don't move well is because you've gotten so tight with your muscles they don't stretch, your patella doesn't move, and you've
Yeah.
lost your roll glide slide mechanism. If we would strengthen the muscles of the thigh and the knee,
Mm-hmm.
you won't get all this rubbing, but we're not strengthening them
It
properly.
accelerates the
So,
pain.
yes, I try to do all of these things in the home. They have a hospital bed, they have everything sterile, you got all this room. When you come to the house, there's a dresser and the bed's up against the wall. We
Yeah.
need to just shift the room around to make it more ideal for the client.
Mm-hmm.
Change is hard. And I
Mm-hmm.
said, I'd rather you be safe and functional than have a fall. We'll keep everything in here. I just need to redistribute it.
Yes, yes, and especially in the NCOA and we have many resources where you can check, guys.
Mhm.
Some home modifications like what Dr. Brown's talking, we can add more on adding night lights, removing stuff from your steps, you know. Some of you will have figurines, plants all over in your pathways. So limit those. Throw the rugs. That's why they call it throw rugs, you know, something
Right.
like that. But we have now some tapes that if you really love that particular rug or mat, you can put some adhesives or tapes on the bottom
Yes.
just to be more secured. Definitely check out. So Dr. Brown, that's really amazing, and you really help a lot. There's more things that you do. Of course, I know that. But how can we connect with you? Definitely, they want to learn more, but how can we connect with you, Dr. Brown?
So I'm just starting a YouTube channel. We got to get a disclaimer up there, but I'm going to start posting videos on simple exercise and techniques and things you can do for a better ankle foot orthosis.
Okay.
So my YouTube channel is Dr. Jennifaye Brown.
Mm-hmm.
And then I'm on LinkedIn. Again, Dr. Jennifaye, I think it's B for my middle initial Brown. I have a website, so it's jvbneuropt.com. So it's my name, my initials, J as in Jack, V as in Victor, B as in boy, neuropt.com.
Mm-hmm.
And then when you go to my website, you can see my email, my phone number. I can get a 15-minute free consultation. I can do it by Teams if you have Zoom and you want to do that. And so I consult with a lot of people. Someone had an issue in Alabama by the Panhandle. And we talked via email, and then I sent them some documents and some forms and what to do. And they said it was perfect. We had a checklist of what we could do in the home and what needed to be done. I also told them how to progress the exercises. We're giving our clients exercises, but we're not progressing them. Teach them the progression because you don't know what they're going to get in home health. So
Mm-hmm.
teach the progression and then teach them when they should get a follow up or a tune up.
Wow, yes, yes. Follow up, and then they need to be compliant. So you need to check. These are the time we need to have a follow up. All right.
Yes.
Thank you so much, Dr. Brown. I learned a
You're
lot from you.
welcome.
And definitely, I'm sure with our listeners learns a lot from you. And then you have your book. What's the title of it? Brace Yourself, and
The
they can
name of the
get
book
it in
is
Amazon.
I'm sorry. The name of the book is Brace Yourself.
Mm-hmm.
Everything you need to know about AFOs after stroke. It is available at Amazon.
Brace yourself. Yeah. I like that. Because it's an AFO, but it's a double meaning. Brace yourself and the brace from the AFO thing. Great, great, great.
Correct.
Thank you so much, Doctor.
Correct.
Any other remarks or any other tips for our listeners that you want to say before we close? Mm-hmm.
I just want them to engage in exercise and physical activity for a healthier life as their age. Just don't exercise to fix the problem from the disease process. Exercise because it's good for your whole body, your mind, your spirit. And exercise with intention and purpose so that you can do something and with other people. So any type of exercise or physical activity. I don't care if it's gardening, I don't care if it's playing bridge, you know, do something that will encourage movement with someone.
That's good. Make them happy. Dancing even is an
Yes,
exercise.
dancing. We did
Love
it in the pool
Zumba.
today.
Yeah, like music. Music is therapy. So guys,
Yes.
there's many other ways. If you don't like to hear the word exercise because you get tired already just by listening of that word, just look at it as like movement or
Yes.
like dancing. So you don't think
Yes.
it's you're doing therapy or exercise. So connect with us, connect with Dr. Brown. We are available online. I will going to post all her like website and other social media, and that way you can connect with her. She's based in South Carolina, but definitely she's available via online. You can connect with her, all right? Thank you, Dr. Brown.
Thank you. Bye-bye.
Hi, thank you everyone. So it's me again, Dr. Jenny, physical therapist, doctor physical therapist, and we are available on online balance and fall support group. And if you have any questions, connect with us. All right. Bye for now, guys. Thank you.